Good evening, everyone. So, this week we'll be discussing the therapy of HIV infection, and we will divide it into two parts. The part one will discuss NRTIs and NNRTIs, while the second part will discuss protease inhibitor, integrase inhibitor, and all the other different classes of drugs. Okay, so make sure that before starting this lecture, you go back 1 or 2 weeks and you see the life cycle of HIV video series so that you have an understanding of what actually happens when the virus infects the cell and stays inside the body and how does the body respond to it. That will make it quite easier to understand wherever these kind of drugs are going to act and how do they act. If you know how they act, you have a certain understanding of the side effects that they do create. But we'll discuss a list of important drugs, important from the exam point of view and from bio point of view, and as venereologist we'll discuss some of the few of the drugs which are very important for us to understand. Clear? So without much further ado, we'll start our discussion on antiretroviral therapy part 1. In this part we'll be discussing the NRTI drugs and the NNRTI drugs. Okay, so let's move forward. The first antiretroviral agent to be made was Zidovudine, which was in 1987. But the issue was that at that point of time, the treatment was with one class of drug or a single drug, and that led to frequent treatment failure. So then a decision was made to combine drugs. Okay, so the combination therapy was started after that because of frequent treatment failure. So combination therapy. After a European study in 1995, dual NRTI therapy, that means using two drugs. You have one NRTI and another NRTI. The difference being that since NRTI is nucleoside reverse transcriptase inhibitor, so you will use one nucleoside here and another nucleoside, a different nucleoside here. So two drugs in dual NRTI therapy, you have to use two NRTIs, but these NRTIs have to be analogs of different drugs. So you cannot combine, let's say, stavudine with zidovudine. Okay, so you cannot combine similar nucleoside drugs. You'll have to use two different classes of nucleoside drugs, and we'll tell them what we actually mean by that. In 97, protease inhibitors were invented, and then afterwards the treatment turned out to be quite well because HART or highly active ART was now in motion. HART includes dual NRTI and protease inhibitor, or an NNRTI and protease inhibitor. But in the current scenario, in the current context, any modification of this is also HART. So you have one NRTI, protease inhibitor, and then protease inhibitor, it can be changed or switched with, let's say, integrase inhibitor or maturation inhibitor, okay, or fusion inhibitor. In fact, one of these drugs can also be switched depending on specific patient, whether they're developing any kind of side effects or whether that drug has developed resistance. So this kind of switching of drugs, but a combination of at least 3 different classes of drug is what is highly active ART. So all of these drugs are ART, but the combination of 3 different classes of drugs together is highly active ART, and that is the difference between ART and HART. Clear? So HART is a combination of drugs. Let's move forward. So coming to the antiretroviral drugs, there are majorly 6 classes of drugs. You have the NRTI, which is nucleoside reverse transcriptase inhibitor. You have NNRTI, which is non-nucleoside reverse transcriptase inhibitor. Then you have protease inhibitors, integrase inhibitors, maturation inhibitors, and fusion inhibitors. Clear? So majorly 6 classes. In the part 1 of the video series, that is what we are discussing right now, we'll discuss NRTIs and NNRTIs. In the part 2, we'll discuss protease inhibitors, integrase inhibitors, maturation inhibitors, and fusion inhibitors. So all this will be discussed in the second part. Now this is a brief diagram of the life cycle of HIV. I will not go into detail because we have a detailed lecture previously about 2 weeks back. But this is just to show wherever these kind of drugs will act, or at what part of HIV life cycle these drugs act. So let's start with point number 1. You have the binding of HIV to the immune cells. Now here CCR5 and CCR5 antagonist, attachment inhibitors, and post-attachment inhibitors will act. When the inhibition has happened, it will fuse with the membrane of the host cell, and here the fusion inhibitors will act, as the name suggests. When the capsid goes inside, the capsid is covered with capsomeres or particles around the capsid, and here the capsid inhibitors will act. During the translocation of capsid inside the nucleus, the viral RNA is being converted into viral DNA. So here reverse transcriptase inhibitors will act, all your NRTIs and NNRTIs. When the viral DNA has been formed, it will integrate itself in the host DNA, and here integrase inhibitors will act. Okay. After the virus has integrated its DNA in the host DNA, there's no drug as of now that can remove that. Okay, so when the viral DNA has entered the host DNA, it will remain there and continue to make new viruses or remain latent there for years altogether. Clear? Now after that, the viral DNA will form other proteins, other RNAs, and we have discussed that in detail in the lecture 2 weeks back. After that, the RNAs, mRNAs will get translated into various proteins. These proteins will mature together and form new viruses, and there you can have maturation inhibitors that can work when the virus is being matured into newer daughter viruses. And also all the proteins are cut together, spliced into individual components by proteases, and there the protease inhibitor would work. Clear? So these are the areas of different part of life cycle of HIV where different classes of drugs work. And if you want a detailed discussion on the HIV life cycle, we have a separate video on that. You just go through it, and after that it will make it very easy for you to understand what all different classes of drugs we deal with in antiretroviral therapy. Clear? Let's move forward. Now these are the 6 major classes of antiretroviral drugs, and this is the minimum that you should know. So let's start with the first class. The first class is NRTI. Okay, so NRTI are fake DNA analogs. We know that DNA is made by purines and pyrimidines, ACTG, and one more U if you're dealing with RNA, uracil. So these are the natural host nucleotides. Now what happens is that HIV virus utilizes natural host nucleotides to make its own DNA. So what we do is we create fake nucleotides that can go inside and attach to the replicating viral DNA and stop replication. Okay. So we'll discuss that when we'll discuss mechanism of action. So what exactly are NRTIs? These are nucleoside reverse transcriptase inhibitors. So these are nucleosides that will block the action of reverse transcriptase. And since the action of reverse transcriptase is to incorporate nucleosides, these NRTIs will act on the active site of reverse transcriptase, because that is the action of reverse transcriptase. Reverse transcriptase attaches newer nucleotides to form RNA or DNA, whatever the case may be. So if you have fake nucleotides, they will act or attach themselves on the active site. Example of NRTIs include Zidovudine, Didanosine, Stavudine, Lamivudine, Abacavir, Tenofovir, Emtricitabine, and Zalcitabine is discontinued, so we will not be discussing this. So we will discuss each of these drugs separately. The second class is NNRTI. So NNRTI are non-nucleotide reverse transcriptase inhibitors. Clear? Now these are fake molecules which will attach at the non-active site. Non-active site, not the active site of reverse transcriptase, and after attaching on the non-active site, it will create conformational changes in the enzyme of reverse transcriptase, and you will not be able to make newer DNA strand from RNA strands. Clear? So NRTI acts on the active site, NNRTI acts on the non-active site. The example include Nevirapine, Efavirenz, and Efavirenz. So we'll discuss these drugs in detail. Okay. Other drugs are protease inhibitor, which will block the HIV protease, integrase inhibitor that will block the enzyme integrase, CCR5 antagonist or maturation inhibitors, which will prevent the virus from getting inside the C cell after attaching from CCR5 co-stimulatory molecule. And then here GP41 blocker, which is a fusion inhibitor. Remember, we have discussed that in the life cycle of HIV, that GP120 is for attachment and GP41 is for fusion. How it works, we have discussed that in the lecture. So blocking GP41 prevents the fusion of virus to the cell, and the membranes don't fuse together and the capsid doesn't go inside, and that is where enfuvirtide actually works. Clear? So at this point in this lecture, we'll just restrict our discussion on the first two classes, NRTI and NNRTIs. Let's move forward. So with that background, let's start a discussion on individual nucleoside reverse transcriptase inhibitors. Let's move forward. So NRTIs are synthetic analogs, so synthetically made of naturally occurring purine and pyrimidine analogs. So you have purines and pyrimidines which are naturally present in the host cells. The HIV virus utilizes these purines and pyrimidines and incorporate to form viral DNA. But now we are putting it synthetic analogs which will come and block the reverse transcriptase. They cause competitive inhibition of HIV-1 reverse transcriptase enzyme. And because of that inhibition, the chain terminates prematurely. So before the entire DNA has been formed, you stop the process in between. In dual NRTI therapy, which was recommended by a European study, two agents to different purines of pyrimidine bases have to be used. So if you have a synthetic adenosine and a synthetic thymosin, not thymosin, what you have to do is you cannot use it for the same class, you have to use a different class. So one as synthetic guanosine and then synthetic adenosine, and then you can combine them, use them. You cannot use two purine as NRTIs or two pyrimidine analogs as NRTIs. It is recommended to use a purine analog and a pyrimidine analog together in dual NRTI therapy. Oral bioavailability of different drugs range from 25 to 90%. Now, this is a very important point. All NRTIs are pro-drugs. They have to be converted into triphosphate forms except tenofovir. So, tenofovir, even if it is put in a nucleoside reverse transcriptase inhibitor, is actually a nucleotide reverse transcriptase inhibitor. Reverse transcriptase inhibitor. Okay, so all NRTIs are nucleoside reverse transcriptase inhibitor except tenofovir. Tenofovir is actually a nucleotide reverse transcriptase inhibitor, and I've told you that nucleoside has to be converted into a nucleotide by phosphorylation. Okay, by phosphorylation, and that is why all our prodrugs, all NRTIs have to be phosphorylated to convert into the nucleotide form in order to get incorporated, except tenofovir, which is a nucleotide beforehand. Clear? Let's move forward. So the example of NRTIs include Zidovudine, Stavudine, Abacavir, Lamivudine, Tenofovir. Remember, tenofovir is a nucleotide reverse transcriptase inhibitor, emtricitabine, and didanosine. Clear? So we'll discuss each of these drugs very quickly, and let's go further. The first drug that we'll discuss is Zidovudine. Zidovudine has been approved to be used in adults and infants more than 3 months. Clear? It is available in liquid form 10 mg per ml and tablets of 300 100 IV suspension of 10 mg per ml also. Now, we'll just discuss few important points about Zidovudine. Zidovudine has hepatic metabolism, so it is metabolized by liver and eliminated by renal elimination with significant tubular secretion. So remember this line. This line is important, that Zidovudine is metabolized by liver, excreted in urine with significant tubular excretion. So it is excreted through the glomerulus also, and the tubules, the renal tubules also secrete extra drug in the urine. Now, Zidovudine is very helpful drug to limit mother-to-child transmission. In fact, it has been shown that it decreases mother-to-child transmission by about 70%. Clear? Now, the side effects include anemia, because these are reverse transcriptase inhibitors. They act on nuclear level, so rapidly proliferating cells get damaged. So, because of bone marrow suppression, the side effects include anemia, myopathy, lactic acidosis, and skin and nail hyperpigmentation. Clear? So whenever next time you see a patient on anti-retroviral therapy, especially Zidovudine, try to examine the nails and see if you can pinpoint the skin and nail pigmentation. Clear? So remember, hepatic metabolism, kidney elimination with significant renal tubular excretion. Hi everyone, hope you're liking this lecture, and I hope you're finding studying HIV beneficial. Again, I'm coming you to request again for the bid for Delhi for Dermacon 2028, and from support of IDBL Delhi branch, I would like to request you to bid for or to support us in organizing Dermacon 2028. So let's come together, let's meet in Delhi and take part in this academic extravaganza known as Dermacon 2028. Let's see you in a few years from now, and happy learning. The fourth NRTI is Lamivudine. Lamivudine is a negative enantiomer of a synthetic citidine analogs. Okay, so citidine analog. The action is more on HIV-1. Lamivudine acts more on HIV-1 than HIV-2 and some action on against hepatitis B. Now, Lamivudine is one of the major NRTIs in use. So, all the guidelines that you see, especially NACO or WHO, CDC, Lamivudine is one of the first line NRTI to be used. Remember, there is always a combination of antiretroviral drugs, and one of those drugs in the first level combination is Lamivudine. Clear? So, it's a very effective drug. It is excreted unchanged in urine. Roughly about 70% is excreted unchanged in the urine. So urine elimination. So kidneys need to be functioning properly. Side effects include rash and a little bit of, not little bit, significant hepatitis and transaminitis. Clear? So Lamivudine. In fact, myopathy has also been reported. Clear? So that is Lamivudine. Remember, Lamivudine, one of the best drugs, first line drug to be included in combination therapy of HIV and eliminated about 70% unchanged in urine. Clear? Let's move forward. The fifth NRTI is Tenofovir. Tenofovir again is a very good drug. One of the inclusions in nearly all guidelines against HIV, you will find Tenofovir there. The reason being that tenofovir is a nucleotide. So we have explained before multiple times that tenofovir is a nucleotide and it bypasses the rate determining step of phosphorylation. In fact, in the structure, you can see the phosphate group. Okay, so tenofovir, T for tenofovir, T for nucleotide. Nucleotide. So remember this. You have to take this with fatty meals. Okay, it has poor CSF penetration because of an anionic charge. It is not able to go inside the brain. If you need a good CSF penetration, use abacavir. Okay, so tenofovir doesn't go good enough inside the CSF and will not be able to help that much in HIV-induced CNS symptoms or CNS infection. It's better to use abacavir. So it has poor CSF penetration, a significant renal elimination with renal tubular secretion. So eliminated by kidneys. So we can say that most of the drugs are eliminated by kidneys. A few exceptions are there where liver does the metabolism. Now, since this drug tenofovir has significant renal tubular secretion, the side effects include proximal tubulopathy. So remember T for tenofovir and T for tubulopathy. Tubulopathy. So just remember this, tenofovir. Clear? Now there are other side effects, isn't there? You have myopathy, you have lactic acidosis, you have dyslipidemia, you have osteopenia, all the side effects which are there in NRTIs that is present. One important side effect that you have to take care is proximal tubulopathy is seen. So how do we diagnose this? You have hypophosphatemia, you have proteinuria, amino aciduria, glasuria. So these are the features of tubular damage or proximal renal tubule damage. Let's move forward. Now, NRTIs side effects. You see side effects in the form of mitochondrial toxicity. It damages the mitochondria. These symptoms are similar to mitochondriopathies, like you see symptoms in the genetically acquired mitochondriopathy. Symptoms are same. Other side effects include hepatic statosis, myopathy, peripheral neuropathy, pancreatitis, lipoatrophy, lactic acidosis, dyslipidemia, osteopenia, weakness and myalgia. Abacavir hypersensitivity reaction, which is specific to abacavir, can be nearly fatal on reprovocation. Coronary vascular disease and higher risk of MI. So these are the side effects which is common to all NRTIs. Some drug can cause some side effect in a larger severity, larger intensity. Okay, so like you see abacavir hypersensitivity reaction specific to abacavir, but all NRTIs can cause a rash as their side effects. Okay, you can see a pancreatitis as an important side effect in didanosine, but all NRTIs can cause to some extent pancreatitis. It depends on individual to individual. Make sure you're looking at all the side effects if they develop in your patient or not. Clear? Let's move forward. Hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. Um, you get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video. So, after discussion on nucleoside reverse transcriptase inhibitor, we'll quickly discuss non-nucleoside reverse transcriptase inhibitor. Clear? So these don't have much drugs. I think we'll discuss only one or two drugs and then we'll move forward. Clear? So let's start with non-nucleoside reverse transcriptase inhibitor. Now, NNRTIs, they bind non-competitively. So it's a non-competitive inhibition. In NRTIs, that was competitive inhibition. So it binds non-competitively to the P66 subunit of HIV reverse transcriptase at a hydrophobic pocket. No need to remember everything. Just remember, it does not bind at the active site. It binds at the at another site, not the active site, another site, and binds non-competitively. Just remember that. So it binds and changes the conformation of the enzyme and halts viral replication. Clear about it? NNRTIs have good CNS penetration, so you can add it in cases of HIV CNS infection. NNRTIs are also CYP450 inducer, that means they are enzyme inducer. And we have discussed that a lot of NRTIs are metabolized by liver, so you may need a certain kind of dose adjustment while using NRTIs with NNRTIs. Clear? So you have two generations of NNRTIs, the first and the second generation. The first generation include Efavirenz and Nevirapine. Lamivudine is also there but not used now. The second generation is Efavirenz and Rilpivirine. Rilpivirine is under trial, so we'll discuss only Efavirenz. Remember, like NRTIs, if there's resistance to one NNRTI, the chances of having cross resistance to other NNRTIs is also increased. Okay, so we'll discuss first generation Efavirenz and Nevirapine and second generation Efavirenz. Okay, let's move forward. Let's discuss our first NNRTI, Efavirenz. Efavirenz has long half-life, so you require OD dosing, once a day dosing. Empty stomach, it has to get empty stomach, and because it's an OD dosing, it's a very good drug to be used in combination therapy. Remember, we prefer OD dosing drugs as in combination therapy, so that all you have to do is take one tablet a day. It has good CSF penetration. We have discussed that NNRTIs have good CSF penetration. It has hepatic elimination. Now remember, I've told you that NNRTIs are CYP enzyme inducers, but they are also metabolized by the same cytochrome enzymes like CYP2B4 or CYP3A4. What I mean to say is, Efavirenz increases CYP, and by increasing CYP, it is increasing its metabolism. So Efavirenz is actually increasing its own degradation, and that is known as auto-induction of metabolism. Clear? So you might have to change the dose, especially in the first 2 weeks of all NRTIs, because they have the ability to auto-induce their metabolism by inducing cytochrome P enzymes. Side effects include pregnancy, you can have neural tube defects, rash, like all drugs, it can cause a rash, CNS toxicity with Efavirenz. Why? Because good CSF penetration is there. So it can go at the brain, so it can cause brain specific symptoms. Symptoms include insomnia, dizziness, vivid dreams, frank psychosis, and depression. And these are specific to Efavirenz. So whenever you need to write a short note on Efavirenz, make sure you mention dizziness, vivid dreams, psychosis, and depression. Clear? Let's move forward. The second NNRTI is Nevirapine. So Nevirapine has a structure similar to benzodiazepine. It has a long half-life, so single-day dosing is there, and it is unaffected by food. Now remember, like all NNRTIs, it is an auto-inducer of metabolism, especially when the treatment is less than 2 weeks. So remember, when you start ART, it is lifelong. You have to take it for life. In the initial 2 weeks, in the first 2 weeks, Nevirapine can induce its own metabolism and destroy itself, or so that you need to maybe use, you have to wait for 2 weeks and then give a proper dose. Clear? Side effects include rash, about in 10% of patients, severe enough to cause Steven-Johnson syndrome, hypersensitivity, hepatotoxicity. So, in order to avoid hepatotoxicity, you avoid the ART naive patient with CD4 counts less than 250. Okay, because of immune reconstitution, the drug can easily damage the liver. Clear? Let's move forward. So with that, not a short per se, but a good enough discussion on NRTI and NNRTI is ending. These are the reading recommendations. I would suggest that you should read the NACO guidelines for treatment if you have time. It's a very big guidelines. It's about nearly 500 pages, so you won't be able to go through it. But certain tables are good, so you just go through the tables. And I would suggest that you look at the HIV info for new FDA approved drugs, or you look at the WHO guidelines. They will give you good information. And these are the recommendation. Otherwise, what all is covered as far as NNRTI and NRTI are concerned in this video lecture, that's enough that you should know. Clear? Again, requesting to become a member of the channel. You should consider becoming a Ruby member if you find this videos effective. But do remember, I plan to discontinue Ruby member in the coming months. And if you really think that these videos are helping you to understand basic concepts in dermatology, do consider becoming a Sapphire member. That helps me a lot. In fact, I've started to add one or two specific videos only for Sapphire members, and they will have access to these videos only. These are some extra points or extra topics. Maybe I'll put a very short videos on doubts that I see in the comment section, or newer drugs that I will put like 1 or 2 minute videos only for Sapphire members as of now. Okay. So with that being said, I should finish this week's discussion on antiretroviral therapy part 1, NRTIs and NNRTIs. If you have any comments, doubts, suggestions or queries, make sure you use the timestamp and put it in the comment section. We'll meet again next week, and next week we'll be discussing all the other 4 classes which are left: protease inhibitors, maturation inhibitors, fusion inhibitors, integrase inhibitors. Okay, and we'll discuss these 4 drugs in detail. And after that, we'll discuss combination therapy or antiretroviral therapy part 3, in which we'll discuss combination of drugs. Clear? And after these 3 lectures, your concept regarding all the antiretroviral treatment regimens, drugs should be somewhat clearer and open to discussion. Clear? So without much further sayings, I shall finish this lecture and we shall meet next week. Till then, bye bye.